to talk about our Regional Opioid Safety Coalitions project. Our goal is to bring communities together to prevent overdose deaths, and in this hour we'll be going through some slides that outline the purpose of the project and how it's structured and what participants will gain from the project. We'll review the timeline and what would make a strong application, and we'll have plenty of time for questions and answers. This webinar will be recorded, and we'll also have a frequently asked questions document on our website. We also welcome personal questions by email or phone call, so please do get a hold of us if you have questions about the project. The agenda for the call today is we're going to go through a little bit of housekeeping, and then we'll go through the purpose of the coalition, the program elements, what you'll need for a successful application, and then we're going to give some examples of a coalition structure. This is not mandated, but it's just helpful examples if you are earlier in your development and want to see how other coalitions have structured their work. Go through the timeline, and again, we'll have plenty of time for questions. As I mentioned, the session will be recorded and available on our website within a week. We did an identical webinar last month. If you attended that webinar, this will pretty much be exactly the same, and that webinar is also recorded and on our website. Your lines are right now muted, so if you have any questions, chat to the host if it's logistical. If you have questions for speakers, feel free to chat to all. There's a chat button that's either red or blue in the right upper hand corner of your screen that you can use. And again, after we're finished the slides, about halfway through, we will open up the lines for questions. We would love your feedback if you, and just ask you to do a very brief evaluation at the end of the webinar and let us know your thoughts. So to get started, why is CHCF doing such a heavy investment in the opioid epidemic? There's many answers to that question. The one personal answer is I think many of us have been impacted by the way prescription painkillers have dramatically increased death, addiction, and just general harm in our community. Many of us have personal stories of friends whose kids had a sports injury, got hooked on the pills, ended up turning to street drugs and heroin. We may know stories of adults with chronic pain taking prescriptions exactly as prescribed and not understanding the interaction with alcohol or a sleep aid. Most people who die from prescription painkiller overdose are taking their pills prescribed from their doctor. And a lot of us are puzzling, how did we get to this point where Vicodin is the #1 drug prescribed across the country and in California, and where in California there's enough morphine equivalents prescribed that every one of us could take Vicodin around the clock for an entire month, man, woman, and child. And there's a lot of things that led us to this place. When I was trained as a physician, we were all taught that we were under-treating pain, especially among the poor and especially with people of different races and classes. We also had a lot of information that was told to us by pharmaceutical companies, but then ended up being understood as common knowledge. We all believed that the addiction potential of these drugs was very low when used for chronic pain. We all thought that it was natural for people to need more and more of this pain medicine as time went on, and so we started using doses that were unprecedented and never seen outside of hospice without realizing what we were doing harm. And all of us in this, we in the medical system who created this epidemic really thought we were helping people, and it's only become recently that we've truly understood the impact of long-term opioid use. And that it's not that different whether people are addicted to pain pills or whether they're using them at high doses for long periods of time, that there is a type of brain damage that happens where with long-term use, people stop being able to produce dopamine, which is a core neurotransmitter that helps us organize our life, motivate ourselves, understand consequences, and that when people are suddenly cut off from this after being this dependent, the consequences can be disastrous. So we're really at a pivotal time of this epidemic where we're not only losing people because of overdoses, taking the drugs as prescribed, but we're really risking swinging to the other side and having the pendulum go to a place where people who are dependent on these medications are cut off, don't have access to any physician or care provider who can help them either wean off gradually or could help them with opioid replacement. And then we're at risk for those people that have other desperate measures, turn to street drugs, turn to heroin, or even suicide. So this is a real reason why California Healthcare Foundation is making a commitment to work across the state to try and work on this problem, both because of the personal and social costs, but also because of the high medical cost. California Healthcare Foundation has a long history of working on improving health care for all Californians, and the cost of the opioid epidemic is taking away valuable health care dollars that could be used for other purposes to help people stay healthy. So again, we're at a time of great opportunity where if we tackle this epidemic well, we really think that together we can impact overdose deaths. And we have a very aggressive stretch goal to try and decrease opioid overdose deaths over 3 years by 30%. And the goal is to do this as a community, because even though this problem originated in the healthcare system, it impacts all sectors across our society. And we've really seen the potential for collective impact of not just healthcare providers, but people in the community, law enforcement, schools, others working together to try and solve this. We are focusing on the 3 areas that were prioritized by the federal government in Obama's new initiative. And there's a logic to this. The first is to support safe prescribing practices, mainly to prevent an entire new generation of people of becoming dependent on these medications. So this is helping clinics, hospitals, physicians, nurses work in a system that supports safe opioid use. And not to mean that we're in a place where we never prescribe opioids, and that's again a risk of this pendulum swing. Dr. Andy Rubenstein, who gave a talk the other day here in Oakland, said opioids are not good and opioids are not bad, they're just a molecule. And none of us would want to go through cancer without having access to them. We certainly want to make sure that all of the work we do on opioids doesn't negatively impact the work we're doing to try and spread palliative care, for example. So number 1, supporting safe prescribing practices really means finding judicious use for opioids and using them safely. The second is expanding access to medication-assisted addiction treatment, and there's excellent evidence that medications, ideally with social supports and counseling, but even without those, can dramatically improve people's ability to recover from opioid dependence or addiction and live functional lives. Some people need it permanently, and some people can wean off over time. But then it's very important as we address this epidemic to not abandon the population of people who become dependent on this. Another quote I'll give is from Dr. Corey Waller, who runs a clinic in Grand Rapids, and he says that if someone has a pancreas that doesn't produce insulin, we'll give them insulin all day long. If they're a diabetic and they go out and binge on a box of Krispy Kremes, we don't have them come in and say, you binged on Krispy Kremes, we're not going to give you insulin anymore. We recognize they have a chronic disease with good days and bad days. Likewise, if someone has a brain that's been damaged so that they don't produce dopamine anymore and they need opioids on a daily basis to function, we, of course, in the medical community, if we see that they've had a bad day and they borrowed a Vicodin from a friend, we react with punishment. We're not going to give you opioids anymore. We're going to cut you off without a plan. And that, again, puts people at tremendous risk. Thinking of opioid dependence as a chronic disease that sometimes needs long-term or opioid replacement is a way to make sure that we don't cause harm as we improve our safe prescribing practices. So there's many parts of the state which don't have access to medication-assisted addiction treatment, and we're aiming to change that. And finally, the last category is to decrease deaths, and this is through naloxone, which is an antidote which can be used by community members or first responders to save a life when someone stopped breathing from opioid use. The way for this objective, the way for this coalition will work is we'll provide an opportunity for people to learn from experts and from peers and have supports of faculty and a coach to be able to make progress on this epidemic in your community. So a little more detail on this first strategy of promoting safe prescribing practices. There's many examples of very easy-to-use protocols that have been developed. A one-pager for the emergency department that's been adopted in many hospitals across the state that focuses on helping emergency practitioners understand when to give opioids and when not, focusing on acute pain, the small doses and only the amount that's needed, and avoiding the 90-day cliff, which is a way to describe the fact that 2/3 of people who are using opioids 90 days after an injury become chronic users. So it's really helping people make sure that if they're using opioids for a short period of time that we don't continue them long term. And then in chronic pain, there's some very commonly understood best practices that were emphasized by the recent Medical Board opioid prescribing guidelines. Avoiding high-risk combinations, benzos and opioids and methadone are the drugs that are highest, have the highest association with overdose deaths. To monitor, form, respond to concerning behaviors using the CURES database that is going through a redesign and will be much more accessible and easy to use by prescribers who are looking to see when people are filling prescriptions and by whom. Utilizing buprenorphine, which is a treatment for opioid use disorder. And then recognizing high-risk thresholds. We now understand that doses above 100 milligrams morphine equivalents and above 40 milligrams of methadone a day put people at very high risk. And so the goal is to avoid escalating above these doses and to help people on higher doses transition to lower doses very slowly when possible. Another example of an activity in the category of safe prescribing practices is finding a way to share patient information in real time for use of providers when they're taking care of patients. And there's a product called EDDI that was spread across Oregon and Washington and is now starting to get a foothold in California that is a very low-cost way for hospital emergency departments, primary care providers, and health plans to share information in real time to identify when people are going to the emergency room frequently, to know if they've, for example, received 5 CAT scans in the last week to avoid another CAT scan, or to know when someone is going to the emergency department as part of their addiction to recognize that addiction and get people help. And there's some good data that this intervention has dropped emergency department visits, dropped emergency department prescriptions, and it's something that would be another example of an activity that a coalition could choose to do within this first strategy. The California Healthcare Foundation is not mandating what you do to support safe prescribing practices in your community. If you're part of this project, that we would expect you to work within your steering committee to identify what's most needed in your community and to identify what interventions in this category would make the most sense. The second strategy is to expand access to medication-assisted treatment, whether that's through an established methadone treatment program and adding buprenorphine as an option to that program, or in areas that may not have that access or where that program is not providing enough access to integrate buprenorphine into primary care. And there's many different models where that has been done successfully. Some doctors just doing the training and taking it on themselves, sometimes having a physician assistant or nurse practitioner or a nurse care manager do most of the patient management and education and have a doctor as a prescriber. Others have set up virtual telemedicine access or have pharmacy-run clinics. There's many ways to incorporate buprenorphine into practice, and there's now a federal grant opportunity for any federally qualified clinic to receive up to $325,000 per year indefinitely to integrate substance use treatment within their primary care practice. There's lots of focus nationally on no longer saying if you have addiction, you get treated in one silo, if you have mental health problems in another silo, and primary care is another silo. We're really working hard to make sure that those services are available for patients with addiction or dependence. And then finally, this third strategy is to spread the use of naloxone, and there's many ways that communities have done this. Some have worked with needle exchange programs to focus on those with heroin addiction. Others have encouraged primary care providers to routinely prescribe naloxone for their patients who are using opioids chronically. And this has been proven to be very effective even if the naloxone is never used, mainly because it allows a conversation with the prescriber and the patient about how these medications can be dangerous. And sometimes patients may not have really clearly understood that these medications could do harm. There's been efforts to have community spread to family members, and there's many stories like the story that's promoted in this ad about mothers and grandparents and friends and family saving lives. And there was recently a post out of San Francisco where they noticed a big increase in overdose with this particular potent fentanyl that was on the street, and they used naloxone many, many times and had no deaths despite that very strong drug that was out there. So again, 3 different priorities: safe prescribing, medication-assisted treatment, and naloxone, and each community can look at what they want to do within that category. Another use of naloxone, for example, is first responders, having all of them equipped with this to reverse overdoses when they come upon them. So these are the elements of what this program offers people who participate. We're going to be doing 3 mandatory full-day sessions where we're going to be bringing in experts from counties that have been doing this for years who can share the strategies that they've used. Our first convening is going to be kicked off by Dr. Karen Smith, our Public Health Director, and there's going to be opportunities for coalitions to learn from each other and learn from experts about things like communications. How do you develop a communication strategy to help your whole community get on board? There's going to be another one in September, and we'll choose a date based on what makes most sense for participants, and another one in May of 2017 so that we can share what everyone has learned. We're going to be having periodic webinars where we're going to be sharing strategies and how to get over challenges over the course of the project. Expert mentors will be paired with counties that are similar to them. So, for example, San Diego, Marin, and other counties have done a lot of work in this area, and we'll take people who have been leaders in those efforts and pair them with counties who may be earlier in their development. And we, just in case you're interested, those are links so that you could link to their websites to learn more about what they've done. And we'll be, of course, sharing with other counties that have done a lot of work across the state. There'll be coaching available to Christine Cristobal, who is going to be our project manager and coach. We'll be checking with each coalition leader on a monthly basis to talk about goals and measures and action steps and help people move along the path. It's one of those things that no one really thinks about needing a coach, but if you look at superstar athletes and teams, they get so much further than they would on their own by having someone on the outside coach and encourage them and bring in resources when needed, and we're finding in healthcare that the same principle applies. And then how your coalition structures itself is going to be very different depending on what your needs are. There's some coalitions that have already started working in the opioid epidemic, and others that are just getting started and may need to get some data together, do a kickoff, get the community involved. There's certain core elements of your coalition that we would recommend. For example, having a steering committee that pulls together the different sectors of your community working on this, and then having some task forces or action groups to do a deep dive in a particular part of the epidemic that you're working on is a structure that's worked well for many coalitions to help people move along fast. So what are the criteria for a successful application? I mean, first, we'd like to see a strong proposal that there's either a plan in place or already a broad coalition and that a structure that will sustain progress over time. We don't want to just have this be an 18-month project. This epidemic's not going to be solved in 18 months. Our hope is that by pulling people together and getting people going, that there will be momentum to continue over time. We want to see a strong lead organization. This is obviously a community endeavor, and it doesn't matter to us whether that lead organization is a for-profit, nonprofit, public health, county, medical society. What the lead organization just needs to make sure there's enough infrastructure to support the project, that either through the grant funds or through in-kind support, there's someone who is doing the logistics, pulling the meeting together, documenting next actions, reminding people about what's due. There's all of that logistics and project management is what often makes the difference between people who have good ideas and people who have good ideas that are translated into actions. We want to see a clinical champion and someone who's going to be the lead on the project. This may be different people or the same person. We want to see broad sector commitment. We recognize that in the couple months from the announcement to the time that the application is due, you may not be able to get letters of support from every organization on this list, but we certainly will see that coalitions that have broad representation across all sectors are much stronger applications. If you don't have a key group on this list, then certainly we'd love to see that you've got an outreach plan for that group. Again, we'll get much further in this epidemic if we've reached across outside our typical silos of the medical system or county public health or addiction treatment, but that we're all pulling together to try and work on the same problem. And then once we have several strong applications, one of the factors we'll take into account to finalize the 10 participants will be geographic diversity, how severe the epidemic is in your region, and then the number of people living in your region, so we can see how, what would be the broadest impact. We, of course, recognize that there's some regions that maybe have small numbers in terms of population, but where the epidemic is much worse, and we will take that into account. Again, what we're aiming for is a comprehensive approach. That the ideal is to have a medical system, the recovery system, the ability to pull in the benefit of cures, which is your surveillance monitoring system. There's some type of prevention, education, and ideally law enforcement. Law enforcement is often not at the table when medical groups do their work, but there's some really great stories out there about what happens when people talk to each other when they don't normally talk to each other. And one of my favorite stories comes from a small county where the law enforcement was often very frustrated with the physicians about why every time I arrest someone and put them in jail, when they go out of jail, you start prescribing the same drug we caught them selling. And the physicians hearing that were really frustrated because they say, well, I didn't know he was in jail for selling the drugs I'm giving him. I thought he was just taking them for his pain and he left for a couple months to take care of his mother. Certainly physicians would never share information with law enforcement, but it occurred to them that if the law enforcement would alert the physicians when their name on the pill bottle was involved in an arrest, and that physician would be able to identify this person has a problem. I'm not going to keep giving them that same drug. I'm going to help them get help for the problem. So again, identifying where communication can improve care. This is a slide that came from Marin County's work on Safe Marin, and it's a good way to think about what is the life of a pill and what are the many places that communities can impact in order to increase safe use of prescription and decrease unsafe use. You know, is there a way to impact at the manufacturer level, at the prescriber level, the pharmacy level, safe disposal? There's many, many places where communities can impact, and thinking about not just the prescribers, but at every point where could there be an intervention that can make a difference. And this is another example from Safe Marin of their structure, which worked really well for them, of having a steering committee where they had, it was co-led by the county in terms of county public health, and then other people from the community. They had Office of Education, they had other folks on that group, and then they had action teams which were focused on different parts of the epidemic, where prescribers and pharmacists were working on safe prescribing guidelines and how to identify red flags when there might be concerns. A law enforcement team with public health representation was working on the law enforcement side. There was a data monitoring team which is working on collecting data and having a dashboard, a report card to identify what were the big problem areas and what was the impact of all this work. There's a recovery team working on making sure there was enough services for people who are struggling with addiction and dependence. And then again, a prevention team. So if you go to Safe Marin's website, each of those action teams has specific goals and specific actions and measurements over time. So it's a very good way to organize your coalition. Again, we are not mandating that you adopt this structure. We're just giving some suggestions of what has worked. And again, this is a roadmap for Safe Marin, which is really only a year and a half into their program. But you can see if you're a county that's just starting up, how you might be able to get up to speed quickly through doing a community-wide meeting where they share data based on looking at Marin compared to other counties. It was, I think, shocking to many Marin residents that they were the healthiest county in the state, except for a much higher than expected number of overdose deaths. And then they developed work groups and had other community meetings. So again, something that will be helpful for you. And in the application packet, we put other resources, and we'll be, of course, happy to provide others as well. So the due date is midnight on October 11th. We'll be announcing the participants on October 26th. Because we recognize that we're going to have more applications than those we'll be able to fund, we are offering for those applicants who aren't chosen to be able to attend travel reimbursement, so you can attend the kickoff meeting and potentially attend other future in-person convenings, so that you also will get the benefit of hearing from some of these experts and networking with other counties who are working on the same thing as you are. So we'll have two groups. We'll have a group who's just getting travel costs to go to convenings, and that's why we recommend you hold these dates. And then the other group will be getting a more intensive support, mentorship, coaching as part of this collaborative. We're going to have a kickoff webinar on November 3rd and our in-person convening on November 17th. So again, hold those dates. And then these other dates are to be determined. So Christine Cristobal is on the line, and her email is available, as mine is as well. And we're completely open to answering any questions. So Glenda or Christine, if you can unmute the lines, this is now the time that we'll take questions. And you can chat them, or you can just speak up. Any questions?
Everyone is now unmuted.
Lines are open. Any questions?
Hello. Marisol Zamora here. Can you hear me?
Yes, we can hear you.
Yes, hi. So I'm wondering, do we target 3 priority areas, or are we only required to target one of the areas?
So I had trouble understanding you, but I think what you asked is, do you have to target something in all 3 areas? And the answer is yes. This is something that we feel strongly about because we don't want a community, for example, to just work on safe prescribing, which might be working with emergency doctors to not refill chronic prescriptions and not give refills for opioids, without working also on the attempt to improve addiction treatment and lower deaths with naloxone. We feel like this epidemic will only be solved by working in all 3 areas simultaneously. And so that's why we want you to develop an intervention in each of those 3 areas.
Thank you.
Did that answer your question?
Yes, thank you.
Great. Other questions? I can go through a couple of questions that were asked in a previous webinar. One was, can we use the money from the grant to buy naloxone? And our answer to that was that what's most important to us is that there's some type of infrastructure to help identify goals and make progress on those goals. And for most coalitions, that means putting some resources to have a part-time person be a project manager, to pull all these pieces together, make sure the meetings happen, document what's committed to, reminders, things like that. But if you have a way to provide those services in kind so that you have dedicated staff who are working on it, then we're not attached to how you use the $60,000 that come with the grant. Are there other questions? One other question that came up was, who can apply? We encourage counties to get together and apply as a region, if that makes sense in your region. For example, if you're a small county and you've got easy ways of communicating with the counties around you. There's some counties, for example, that have one medical society covering both counties, so that's a logical group to apply together. However, if you're a county the size of LA or San Diego, it may not make sense to unite with another county, just because that would be a pretty big bite to chew.
Kelly, this is Christine. There was also a good question about the data to be used in the application.
Great, I'm glad you brought that up. We had given data in the application comparing different counties, and this data came from CURES, which has been a statewide database that tracks all controlled prescriptions. And this type of data from CURES is going to be available on a regular basis. The California Public Health Department just got a large grant from the CDC that will enable them to work with county health departments to get data on a regular basis on emergency department visits for opioid use, hospitalizations, overdoses, and prescriptions. But if you have other data sources, you are welcome to use them, and many times local data may be stronger than statewide data. Again, we're really trying to, with this project, allow a lot of flexibility, recognizing that California is a very large state with a lot of different regions. And so we recommend that you use whatever data sources make sense. And for example, in the dashboard that we included in the application, there's some that require local data, some metrics that require local data sources, and others that depend on state data. So again, you can adapt to what makes most sense for your own community. Oh, one other question that came up that I want to emphasize is that in the application, if there is going to be someone whose salary is supported by the grant, we do want to know the salary and FTE for that person. But if you are providing in-kind support, we do not need to know the salary or benefit for that person, only the percent FTE. And logically, this is because when many different organizations are collaborating together, salary is typically not something that people want to share. So again, if you are providing in-kind support on the budget form, just put in-kind, and that you don't have to list a salary. Any last questions before we close down? Okay, well, we have our email is available, and this slide deck and webinar is recorded and is available on our website. If you have other questions after we hang up, please reach out.
Thank you.
Thank you so much for your time.